Okay, let's see the first one. Which of the following statements regarding the principles of skin incision is incorrect? Now we take so many surgical incisions. Do we never think of these things? Some come spontaneously, some come at a spinal level. But in the MCQ, it can look a little tricky. So blade number 22 is used for making abdominal incisions. This is correct. Normally for abdomen, we take 21 or 22 or 23. Those knives are normally used for skin incisions on for laparotomy. Skin incisions should be placed along Langer's lines and away from bony prominences. Of course, this is correct. Langer's lines, remember, are lines which talk about the orientation of dermal collagen. So these lines represent the orientation of dermal collagen, and incisions along them are going to have a good cosmetic outcome because the tension is not going to be that much. So the wound healing, the skin incision will be very cosmetic at the end. To convert a circular incision into an elliptical one, the width should be equal to length. So if it's a circular incision and you want to make it elliptical, in an elliptical incision, obviously the length has to be more, the width has to be less. If the width and the length are the same, obviously it will remain a circular incision. I mean, it's just a play upon words. In principle, the length should be 3 times the width. Okay, so if the question comes, this will be the correct answer. The length should be 3 times the width. If the width is 1 centimeter, length should be 3 centimeters. After completing the incision, the scalpel should be placed in the kidney dish. Of course, this is correct. It's a very basic operative protocol that, you never pass the knife from one hand to the other. It should always be put in a kidney tray. So when the nurse will pass it to you, she should pass it in the kidney tray. Once you're done with the incision, put it back in the kidney tray. Don't pass it because there can be a risk of injury. Another very important basic question. Which of the following statements regarding abdominal incision and closure technique is incorrect? Okay, so we are looking at incorrect statement regarding abdominal incisions. Transverse incisions have fewer post-op complications compared to midlines. This is actually correct. Understand, whenever I take a transverse incision, one is it will be along the Langer's line. In the abdomen, the Langer's line are transverse. The stretch on the incision is less. Midline incisions, vertical incisions have more stretch because when the abdomen, pressure increases, the abdomen gets stretched like this laterally. So midline or vertical incisions are at a more stretch. Horizontal or transverse are at a lesser stretch. So this is actually correct. Abdominal incisions you can make either via scalpel or with a cautery, the yellow of the cautery, the cutting current. There is no difference in SSI rates, blood loss, operative time. This is true. So it's totally surgical preference. With scalpel, it looks more clean, but it bleeds more. With a cautery, it looks a little uneven, but it bleeds less. So it's a surgical preference. Net, there is no difference even in blood loss. Mass closure is preferred. This is true. So a lot of other surgical branches, they prefer to do layered closure. But layered versus mass doesn't really matter. In fact, mass closure is better, where you don't even need to go through the muscle, you just need to go through the sheath. And non-absorbable or delayed absorbables are recommended. This is a common practice. Polypropylene or nylon or delayed absorbable PDS are commonly used. The ideal suture length should be approximately 8 times the length of the incision. This is wrong. Because there is a rule which is called Jenkins rule. It tells you the length of the suture material should be adequate. If the length of the suture material is less compared to the length of the incision, you may be compromising in your bites. So what does the rule say? The length of the suture material should be at least 4 times, not 8 times. This is the rule. The length of the suture should be at least 4 times the length of the incision, which means if the incision length, just saying, if the incision is 10 centimeters in length, your suture should be at least 40 centimeters. If it is less, then you have to take a second suture. Right. So this is the logic. It is based on Jenkins rule. Another important question, which of the following statements regarding bowel anastomosis technique is correct? Now, this is directly taken from Bailey, but you should have some basic knowledge about these kind of questions. right? So what does it say? Cocker's method of bowel anastomosis is a two-layer anastomosis. This is true. So what Cocker says that when you are joining two layers of bowel or two parts of bowel ends, let's say I'm doing a small bowel anastomosis, I should do it in two layers. This is correct. One layer should be a full thickness, which means your bite should go through and through. Incorporating all the layers, it should go through serosa, muscularis, submucosa, and mucosa. Then the same on the other side. And then tie it. And this you repeat throughout the circumference, whether you're doing interrupted or continuous. But after doing the first layer of anastomosis, there should be a second layer also. Inverting pseudomuscular stitches. This is true. So Cocker's method has two layers of bowel anastomosis. First do a direct joining, then do an inverting layer where you're taking pseudomuscular sutures. These pseudomuscular sutures are also called as Lambert sutures. So technically, Lambert sutures are nothing but pseudomuscular sutures. Okay, so Lambert sutures are full thickness interrupted sutures. This is wrong. That is not Lambert. Lamberts are seromuscular. Okay, they are seromuscular sutures. In olden times, surgeons used to take only seromuscular, not full thickness. In case of minor bowel discrepancy, like if you are doing an anastomosis of small bowel with colon, obviously small bowel has a much narrower lumen. What to do? How to equalize it? What you do is called as chittling. You do a chittle split to equalize it. Basically, if one bowel is only this much and the other bowel is bigger. Now, how do you join it? One of the bowels you can cut a little bit on one of the borders like this. You cut it. So when you're going to cut it, it becomes a little larger. The opening enlarges, then you can do the anastomosis. This is called as chittling. This is correct. Suture bites during bowel anastomosis should be 1 centimeter deep and 1 centimeter apart. This is wrong. They should be 3 to 5 millimeters deep. So whenever I'm doing a bowel anastomosis, the distances should be 3-4 millimeters and the depth of the bite should be 3-4 millimeters. This 1 centimeter rule is not for bowel, it is actually for rectus sheath. So when I'm doing rectus sheath closure, it should be 1 centimeter deep and 1 centimeter distant. This is for rectus sheath closure, not for bowel closure. Bowel, obviously, 1 centimeter becomes too much gap between consecutive stitches. If it is 1 centimeter, you will get a bowel leak. And if they ask you, what is the ideal technique of small bowel anastomosis? Should you do Cocker's two layer? Should you just do Lambert's? Or should you just do single layer full thickness? No, the best answer today is going to be Halstead's extramucosal single layer. The best answer here, ideal, is going to be Halstead's extramucosal. Okay, this is the best technique of small bowel anastomosis, extramucosal. Extramucosal means you go through serosa, muscularis, and submucosa, sparing the mucosa. And then you do the same on the other side. Go submucosa, muscularis, serosa, and then tie it. Mucosa can be avoided. This is Halstead's single layer extramucosal suturing technique. And if they ask you which of the layers has the maximum strength is in the submucosa. It has all the collagen. So the submucosa has the maximum strength. It is because of the collagen in the submucosa. You know, right? Even when we make suture materials like catgut actually comes from the submucosa. The submucosal collagen is used for making catgut. So that would be the ideal type of bowel anastomosis, extramucosal. Easy question, which of the following regarding principles of surgical drain use is incorrect? So we put surgical drains for various reasons in a operative setting. What is the principle? Which of these is incorrect? Open drains function by gravity dependent drainage. In a way, it's right. It is gravity also, and it is also on capillary action. But mainly it is gravity. That's why they have to be placed at a lower level. So the abdominal drains that you put, they work by gravity and some capillary effect. JP drain operates on the principle of active suction. It's a type of closed drainage system. This is true. So JP drain, Romovac drains, the ones we use in surgery, they have an inherent suction. I don't need to attach it to a suction machine. It has an inbuilt suction effect. So it's a closed drainage system with suction. Open drainage cannot have suction. Obviously, if it's open to the environment. How will you generate a suction? But yes, closed drainage do have suctions like the JP drain. Chest drains are connected to an underwater seal to prevent re-entry of air into pleural cavity. This is correct. Obviously, if it is exposed to the environment, when the person will breathe in, the air from the environment will go in the tube and thereby into the pleural space. So when it is underwater, that negative intrathoracic pressure will not be able to suck the air because there will be a one-way valve. Pigtail catheters are avoided in image-guided intra-abdominal collections due to risk of inadvertent removal. This is false. Pigtail catheters are commonly used. I am sure you have used pigtail catheters for amoebic liver abscess, pyogenic liver abscess, pelvic abscesses. So we use pigtail catheters routinely. There is a risk of inadvertent removal, but that is not a reason to avoid them. They are good for drainage of intra-abdominal collections. So option D here is incorrect. Another question on basic principles of drain. Which of the following regarding the removal of drains is incorrect? Drains placed for post-operative bleed control could be removed after 24 hours if there is no bleeding. This is correct. On what premise is this principle? What is the principle of this? Understand, bleeding post-op can be reactionary. We are putting drains for one reason, to identify reactionary bleed. Best example after thyroidectomy, reactionary bleed. This will normally manifest within 24 hours. All right, it will normally manifest within 24 hours. If there is no bleeding in the first 24 hours, reactionary bleed later is unlikely. Right. So after 24 hours, if the intent was for blood, you can remove it like a thyroidectomy drain. Very common. T-tube is placed. It's a special type of drain. It is placed in the CVD. It should be routinely removed on the 7th post-operative day. This is wrong. Now, there are two answers to this question. One is what we do in clinical practice. In clinical practice, we remove it on the 9th to 10th day. Okay, in clinical practice, it is 9th to 10th day. But if you want to go by the answer given in Bailey, what does Bailey say? Bailey clearly says it should be kept for 2 to 3 weeks because you want the T-tube tract to form well. So if both options are there, go for 2 to 3 weeks. Otherwise, 9 to 10 days, what we follow in clinical practice is also okay, especially if you are using a latex T-tube. A PVC T-tube you will keep for longer because the irritation is lesser, so it takes a longer time for the tract to form. During chest drain removal, this is an important point. A patient is instructed to perform a Valsalva, that is expiration against closed glottis, to prevent re-entry. Obviously, this is correct. I don't want that when the tube is being removed, he should not take a deep breath in while it is being removed. He can take a deep breath and hold it, or he should do Valsalva. Valsalva means exhale forcibly with a closed glottis. Basically, I want the thoracic pressure to be positive, not negative. If it is negative, he is inspiring and I am pulling the tube out. During the removal, some air can get sucked in because you understand when I'm removing it, there is no underwater seal. So at that point of time, he should not inspire. Either he holds his breath at the end of inspiration or best he performs Valsalva. So if any residual air was there, that also will get pushed out. Normally, 15 to 20% surgical drains at the most remain active after 1 week. This is correct. So drains lose their function over a period of time. Either they will get obliterated or they'll lose their suction, they'll get displaced. So normally drains are going to be put for a limited duration for the intent for which it was placed, right? So best answer here is option B. This is a yes and no question. I mean, this is a direct pick from Bailey. Either you know it or you don't. There is no guesswork in this. So quite a straightforward question. This is from a chapter in Bailey where they are asking you what summarizes the core principles of minimal access surgery. Okay, basically we're talking about laparoscopic surgery. What will tell you the core principles? Now, if you use your common sense, you know the first thing that you do in any laparoscopic surgery is insufflation. Only thing is you should know a little bit about these short forms. But the first thing is insufflation, pneumoperitoneum, Mary's needle or open technique, however you choose. So first step in any laparoscopy will be insufflation, generation of pneumoperitoneum. Then the next will be visualization. Means put your camera, telescope, see everything, assess, then put the ports, so instrumentation. Then put your instruments and do whatever you have to do. That is intervention. So it is IVII. Then how you handle the tissue? Remove whatever specimen has to be removed. Be aware, be oriented, and do safely. This is called as in vitrio's principles. Okay, in vitrio's principles. So this is how any surgery is done in laparoscopy. You think of lap chole. First, you will put veris or you will put the trocar by open technique. Then you will put other trocars. You will put the camera. After that, you will do the surgery, put the instruments. Then you will remove the gallbladder after your critical view and everything is attained. Then you look for hemostasis and you close the ports. This is your basic stepwise approach for a cholecystectomy, which you can apply to any laparoscopic surgery. That is on which in vitros is based. This is a trick question. I mean, it's not, it is from a corner of Bailey. Not many of us get the opportunity to see these kind of procedures, but you should know about this for entrances. Which of the following regarding third space endoscopy is correct? Now, third space means what? Normally, you think third space means interstitial space, isn't it? No. Understand, first space are your body cavities. Any body cavity is going to be the first space. Second space is going to be intraluminal. Okay. Third space means what? Third space means submucosal, a plane that you have generated. So third space endoscopy implies going in the submucosal plane. When do I go in the submucosal plane? When I have to do a poem. This is true. So for poem, I go per oral, endoscopic, cut the mucosa, go in the submucosal plane, then do the myotomy. That is poem, it is third space. It will require a full thickness perforation is wrong. In fact, this should not happen. I don't want a full thickness perforation. Otherwise, it will become a notes procedure, where I'm going through the bowel into the GI, into the abdominal cavity, or going through some hollow organ into the abdominal cavity. That is notes. I don't want that to do. I don't want to do that. In fact, full thickness perforation has to be avoided. Submucosal tunneling is a key maneuver. Yes, it is. That's how you will generate the third space, right? And these procedures, stir, G-poem, stir is basically a technique for removal of submucosal tumors, like a cyst or a leiomyoma. Leiomyomas can be removed by stir technique. G-poem is gastric poem for gastroparesis and gastric disorders, right? So these are some of the third space endoscopies that you should know about.